So now coming to the next set of Harrison charts. Basically the surgery chart, but it's given in Harrison's have included. Staging and treatment of hemorrhoids. It's type stage 1, 2, 3 and 4. So there are basically 4 stages. First stage is enlargement of the hemorrhoids with bleeding. Second is protrusion with spontaneous reduction. Third one is protrusion requiring manual reduction and irreducible protrusion. Treatment is increased fiber supplementation, short course of cortisone suppository, sclerotherapy, and infrared coagulation. Stage 2. Again there is fiber supplementation, short course of cortisone suppository, sclerotherapy, and infrared coagulation. Stage 3 is fiber supplementation, short course of cortisone suppository, rubber band ligation, operative hemorrhoidectomy, irreducible protrusion, there is fiber supplementation, cortisone suppository, and operative hemorrhoidectomy. So operative hemorrhoidectomy is done for stage 3 and stage 4 of hemorrhoids. So coming to the pathophysiology of cardiogenic shock. This is acute myocardial infarction, which can lead to left ventricular dysfunction, which can either be systolic or diastolic. Diastolic will increase the left ventricular and diastolic pressure, which will cause lung edema, which will ultimately cause hypoxia and which will lead to ischemia. Ischemia can further lead to death. Left ventricular systolic dysfunction can decrease cardiac output and decrease stroke volume and ultimately lead to hypotension and coronary perfusion and ultimately lead to ischemia. Decrease in cardiac output and decrease in stroke volume can decrease the peripheral perfusion, which can cause vasoconstriction and fluid retention, which will progressively which will progress the left ventricular dysfunction. One more important is stroke volume will reduce, pro-inflammation and catecholamine sensitivity will reduce, contractility will reduce. This can further worsen the left ventricular dysfunction. This can also cause decrease in the coronary perfusion. This can also cause a decrease in the peripheral perfusion. And ultimately it will reduce the cardiac output and stroke volume, right? Any kind of bleeding or transfusion can increase the nitric oxide, can increase the interleukins, can increase the inflammatory markers, which will again reduce the sensitivity, and catecholamine insensitivity will reduce, and ultimately pro-inflammatory state will be there and contractility will reduce. So this is overall the pathophysiology of cardiogenic shock. So cardiogenic shock will non-MI and MI. MI will do an echo, consider invasive angiography and treatment of the underlying cause. If there is myocardial dysfunction and no IVP is required, you can do vasopressors, fluids, vasodilatation, renal replacement therapy and hyperglycemic control. If the patient is not stabilized, you will do temporary percutaneous So utility of echocardiogram in cardiogenic shock or pulmonary edema. First is ventricular dysfunction. So you will get to know whether it affects the left ventricle, right ventricle or biventricular involvement. Etiology, if it's an acute MI, extent of MI, myocardium angiopathy, status of non-culprit infarct zone, presence of mechanical complications. Acute chronic valvular insufficiency, it can determine the etiology like endocarditis, degenerative valve disease, location and hemodynamic consequences. Dynamic left ventricular tract obstruction, Takotsubo syndrome, cardiac tamponade, acute pulmonary embolism, and acute aortic syndrome. Hemodynamically, you can volume assessment of inferior vena cava diameter and inspiratory collapse, estimated pulmonary artery systolic pressure, and estimated left atrial pressure. Therapeutic guidance is guide vasoactive support, monitor response to therapy, mechanical circulatory support decisions, and catheter position and guidance. Pulmonary, it is pleural effusion, lung edema, pneumothorax, and pulmonary infiltration. Causes of relative bradycardia are gram-negative bacteria, that is Salmonella typhi, Rancicilia tularinus, Brucella species, Coxilia brunetti, Leptospira interrogens, Leptospira pneumophilia, and Mycoplasma pneumoniae. Tick-borne organisms like Rickettsia species, Orentilia Susugamushi, that is crab typhus, Babesia species. Others like Corynebacterium, diphtheria, Plasmodium species. Viruses and viral infections are yellow fever virus, dengue virus, viral hemorrhagic fevers, and viral myocarditis. Non-infectious causes are drug fever, beta blocker use, central nervous system lesions, malignant lymphoma, and factitious fever. So now these are important pedigree charts. So you need to identify what is what, right? So when this one male is affected, that is transmitted in all generations, plus in the subsequent generations, male and females are affected equally, and it is also transferred to the next generation. And in a family where there is no disease, it is not transmitted to the next generation. So this is autosomal dominant inheritance. Now coming to the next one, it is it is have is recessive gene, and it is the disease is manifesting in the subsequent generation. So in case of recessive gene, it is affecting the male and the female equally, they are carriers. The male and female both are transmitting the disease to the subsequent generation, and if there is a consanguineous marriage between the affected recessive individuals, then one of the child is getting the disease, the other two, the male and female, both are carriers. So this is autosomal recessive. Autosomal recessive with pseudodominances is when the affected child marries the one of the recessive trait. There is a consanguineous marriage, then the next generation is affected, giving a picture of pseudodominance. Means basically one child, this child over here marries someone with an recessive gene, okay, then the next generation is affected, it will give a pseudo dominance pattern, but it is actually autosomal recessive. Coming to the X linked, here the female is a carrier, female will transfer the gene to the male child. So only the male are affected and females are carriers. So this is an X-linked disease. And in this, if it is X-linked dominant or X-linked recessive, it will be dominant, it will be the next immediate generation will be affected. And X-linked recessive will be carriers, and subsequently two carriers with one male and one, if this male marries a carrier, the subsequent child will be affected. In case of mitochondrial inheritance, the female will transmit the disease to all the children. See, the affected female will transmit the disease to all the children, and there will be no transference of disease by a male. These are all the very important pedigree charts. Visual questions are asked on this many times.